For those of you who don't know me, I'm Dr. Scott Ganz. It's fabulous actually to be here in San Diego because there's a lot of history for me personally with AO. This is actually an anniversary of sorts for me because 30 years ago, because I was only 12 years old at the time, 30 years ago, 1992, I was here presenting for the first time at AO here in San Diego, same place, and 30 years later, here we go. So today we're going to talk about a bunch of different topics that kind of are synergistic to what you just saw, for those of you who were here for the morning session. I'm going to talk about a whole bunch of different concepts that are related mostly to full arch reconstruction, and these we're going to talk about the planning, we're going to talk about execution, we're going to talk about how we do bone grafting, as well as the use of some of the Snoasis products. My philosophy and the basis for everything that I do revolves around diagnosis and treatment planning. And for those of you who have read any of my articles or have seen me present, you know that that's really been my focus with 3D imaging. And as Dr. Devecchio was saying, restoratively driven planning, because our patients are not coming to us for implants, they're coming to us for teeth, of course. And so in order to be able to do that, we have to understand that we can today merge technologies. We have the ability to be able to utilize our digital workflow and the guided surgery concepts for those that are doing guided surgery, or if you're doing it freehand. The concepts of planning should be exactly the same. One of the areas that is kind of confusing to a lot of people when we're talking about full arch reconstruction, when a lot of people are doing alveolectomies, they're taking a lot of bone away, we're doing multiple extractions, why should we be grafting? That's been a question. And I truly believe that should be a major component in many of the cases and many of the patient presentations that we find. And then, of course, I'm going to touch upon something that you may not have heard of, and that's the use of dentin grinding, where we're taking teeth and we're grinding them up and using them as bone product. So we have the ability today, as we just saw very eloquently, to regenerate bone, and we have to be able to understand the tools that we have at our disposal to do that, including the amnion chorion membranes that we just heard wonderfully reviewed by Dr. Devecchio. And so a lot of the concepts that I've talked today will be in my textbook with my wonderful colleagues, Dr. Marco Rinaldi and Angelo Matolo. I'm very proud that that's now in 5 different languages. One of the things that we really want to focus on is that regenerative property of the human body. And we know that we have various different types of protocols, of materials, of membranes that we can utilize. And this is truly one of the most unique that I've encountered over my career. And I think we wouldn't be here if we didn't understand how to best achieve results for our patients. And so whether you're doing a single tooth or you're doing a full arch, and one of the questions was about how large a membrane are you using or what size. And also, I like to use the larger sizes, especially when doing full arch grafting cases. And when I see a picture like this, it's very nice for me to see how this membrane just kind of envelopes over the ridge, allowing the process of healing to be accelerated and improved. And so we use this in all different types of cases, whether it's full arch, whether it's a partial arch, whether it's sinus augmentation, as Dr. Devecchio showed. I'm not going to concentrate on that. I'm going to concentrate more on the full arch restoration concepts today. So when you see a patient like this that's coming into your practice that's going to have teeth extracted, those teeth can be very valuable assets because we can now take them, in many cases, we can put them into a smart dentin grinder, we can grind them up, and we can use them as particulate graft material. This is truly, I think, a game changer when, of course, teeth are present. The only downside is that we have to use those teeth for that patient. We can't just use them on any patient, at least not yet. And so when we have those teeth extracted and then we have these extraction sockets and then we're going to lay a large flap, we're going to do alveolectomy, we're going to do bone reduction, why would we need to do grafting? Well, let's talk about that. And so you just saw a whole bunch of different areas of information from Dr. Del Vecchio on the science behind this. And the reality is that this is a process using the amnion-chorion membrane to be able to enhance the healing process in a way that no other membranes can achieve. And so here's from Dr. Holtzclaw, so a wonderful healing process that shows us an extraction socket. I mean, it truly is a wonderful material to utilize to enhance the healing. And as Dr. Del Vecchio said, it's used in so many different other applications besides our small little world of dentistry and then the small microcosm of what dental implants is. But of course, that's growing and growing, fortunately. And we also have to look at what is out there in terms of the products that are available and what the differences are in terms of how much growth factor. And I think Dr. Del Vecchio did a wonderful job explaining that. And then, of course, when we think about the BioXclude, the membrane, and you see that happy face over there, when we look at the age of the donor, when we look at the placental tissue that is used at 0 years old, this is really, I think, a game changer in the world of healing for dental applications. And we do live surgery courses many times a year, and this is one of the products that we're very happy to partner with Snoasis, with Maxius, and utilize these products. I do in my practice all the time, almost every day, and we do teach this in our live surgery programs. And if you want to talk to Ashley, she's been there many times. In fact, she is just a wonderful part of our faculty at our AIE programs. So when we're looking at a situation like this, as an example, a patient comes in, we plan to do upper and lower full arch extractions, full arch reconstruction with implants. You can see some of the areas that might be of concern for a patient like this, and when we have potential defects. And we think, all full arches may be lumped in one area. We're going to just extract, we're going to level the bone, we're going to put implants in, and everything's going to heal. We do immediate loading, maybe we do delayed loading. But this is one of those unique cases where we start to do these planning, and this is how I do my planning. Everything is with cone beam, of course, and then I do little overlays to make sure I know exactly what I'm looking at. And in this, one of the few cases where we're doing a lower arch, where there's no way I'm putting implants on the lower left side. There's just no way. So we have to stage the approach. And so we have to raise questions about staging the approach. We look at where the nerve is. We look at potential placement of the implants. And I think that's a great suggestion Dr. Del Vecchio came up with in terms of tilted implants here when we're close to that mental nerve to be able to use BioXclude over that area. I think that's a great concept to take home with. So now we're going to look at the defects in the cone beam CT, and as you can see here, I mean, we got some major defects going on. This is maybe a simulated implant, but look at the defect that we would go through from this area here. Sometimes we wonder, how do these patients keep the teeth in their mouth? I mean, if they sneeze real hard, it should go flying across the room. And then we're going to plan here for a tilted implant, as you can see, to avoid the mental nerve. Now you can see here we also have very narrow ridge here, so we have to, sometimes we're thinking about using our osseodensification maybe in areas where we want to actually improve the width of the bone, improve our density, and be able to sometimes get implants into areas where perhaps we wouldn't do it with conventional drilling protocols. And then oftentimes we're looking at defects, we're looking at concavities. Now, from a prosthodontist, which I am a prosthodontist, I'm now a surgical prosthodontist, I guess, but when you're looking at this area here, you can see that there's a concavity, and if we want to build out an emergence profile for the prosthesis, it's nice to have some width to be able to work with, even though we may be taking away some bone. As you can see here, we're going to be removing bone to that level to be able to get the width to place an implant, but maybe there may be some threads exposed, and so therefore we're going to graft, and this is just something that I've been doing for my entire career. And then if you start to look at the immediate extraction placement over here, we can see the periapical areas that we're dealing with. Obviously we see we have clearance to where the nerve is, so that's good. But when we're looking at the planning concepts, we have to truly understand the use of our three-dimensional imaging technologies. As Dr. Del Vecchio showed some of the cases, but you can see here that we need to spend the time with our planning concepts. We need to spend the time understanding the software that we're using. This happens to be Blue Sky Plan from Blue Sky Bio. It's free. So 30 years ago, I lectured on three-dimensional imaging technologies. In fact, I lectured in 94, 95, 96, 97 about this. And now here we are 30 years later, and I'm still talking about the same thing. But what's different is that we have better tools. We have better computers. We have better graphics cards. We have better software. And so we can plan that tilted implant, and we know that we can place a 17 or 30 degree angle multi-unit abutment, avoid the nerve. We can also understand that we can plan for alveolectomy. We can plan for that bone reduction because we have the tools to do that. And this is what separates us in terms of the planning stages from your neighbor, as an example, that may not go through this type of planning. And so when we start to look at that defect that you can see there, we have an extraction of that little tooth that's almost surrounded by nothing, just to show you quickly how we can utilize the software to remove that little fragment, close up a potential fenestration, which truly is not really there. But you remember that we're dealing with cone beam and we're dealing with voxels. And then we can go ahead and we can clean up the model, and we can do whatever we do to be able to enhance the process if we're going to utilize a surgical guide. Now, in this particular case, because of the nature of the mandible and the patient presentation, I decided that it would be, knowing where the landmarks are, it would be very easy to do this as a freehand case. Now, in our textbook, we call that diagnostic freehand. We're using all of these tools so we know exactly where we are when we are entering this bone. And so here we are looking at all of the different ways that we can enhance this planning process. So here we see the large defect, and the question is that defect real? Is that really what we're dealing with? And if you're going to treat that defect so that you can come back later and place an implant, what are you going to use? What are you going to use to fill that defect? What are you going to use to cover that defect? We can use selective transparency. We can see the distance, of course, of the implant to the nerve. We can evaluate everything that we need to know before we touch the scalpel to the patient. And there's the defect area that we're going to be dealing with. And so when we contemplate doing these cases, sometimes we have to stage the placement of the implants because we have defects that are just too large to place an implant at the same time. And so here we can see, again, the 3D planning involved here, and you can see that we're simulating flattening the ridge here, doing our alveolectomy. And so when we have the tools to be able to do that, assess the bone, we can go in and we know what we're dealing with, but sometimes we get surprised. So when I went in here looking at this area after raising the flap, extracting the teeth, I mean, we had a very, very large cystic lesion there. You can see the size of it right here. And we're able to take it out pretty much in one piece. And then the debridement process. And one of the things that I do want to comment on, I happen to use chlorhexidine quite a lot at this stage, because I find that when I irrigate with chlorhexidine, it separates the tissue from the bone. The bone turns white, the tissue starts to come up at you, and you can see these tissue tags, and then we clean everything up. And then we will irrigate with sterile saline to be able to clean that area up and get rid of the chlorhexidine that's in the area. And of course, then when we put implants in, we're still using irrigation, etc. And so now we have this big defect. We still have extraction sockets. We're going to go in. We're going to clean that up. We're going to flatten the ridge. There's a lesion that we took out. We're going to place our implants, the tilted implant here. And you notice that I'm placing the implants below that lingual crest of bone. Because I'm one of those people that always likes to be able to keep that cortical bone intact if I can, and graft over the top of that. And if I have to remove some bone later, that's fine, and oftentimes we do, to put a multi-unit abutment on that's angled because the bone gets in the way. I'd rather have more bone than less bone. And as you can see, look at the size of that defect. It would be very difficult. Although I've done it before, I didn't want to take a risk of placing an implant into that large a defect. So we're going to go in, debride that area out really carefully, put the caps on top of the implants, and now we're going to graft that whole buccal area. And so the question is, do you graft in these cases? Of course. I graft almost every case. Even when we're removing bone, even when we're doing alveolectomies, I like to use the Maxius bone. We use that in all of our courses. I use it in my private practice. I happen to like using the mineralized cortical cancellous bone of different particle sizes, depending upon the defects that we're going to use. And then the question is, what do you do from here? Are you covering this with collagen? Are you covering this with PTFE? Are you covering this with, what are you going to cover it with? Or are you going to cover it with a BioXclude membrane? And so this is based on philosophy and your knowledge and experience of the materials that are at hand. And so now we can see the large amount of volume of graft material. And if you had to take that material from the bottle that you order from Maxius, obviously it's going to cost money. And so wouldn't it be nice if we also had the opportunity to take the teeth that are involved, grind them down, and use them, because that's a lot of bone in that particular area. And now we're going to come back, we'll come back in 5 months, maybe, sometimes 4 months, to be able to go back and place new implants. And we'll take a new cone beam CT. Now, for years I've talked about, obviously, 3D imaging, the use of surgical guides, and in our book we talk about the classifications of guided implant surgical protocols, and this would be called full template guidance. What we just saw would be considered diagnostic freehand. So full template guidance means that we're going to drill the osteotomies, and then we're going to place the implant through the drill guide so we have the most precision that we can get for our procedure. So here's another case. Now we can see this is a case where we have multiple teeth that are going to be extracted, and that is a gold mine, because you can take those teeth, you can use them, you can repurpose them with autologous material for your graft material, and you can get an enormous amount of volume, really an enormous amount of volume. So here's a patient as she comes in. We can see the preoperative condition. She was very, very dissatisfied, the shape of her teeth, the color of her teeth, everything. Obviously, she had all sorts of issues in terms of her oral hygiene. And the procedure that we suggested for her was to be able to do full arch upper and lower implants. So some of the concepts that we utilize preoperatively, of course, are cone beam CT, but we don't stop there. We take our cone beam CT, we take our intra-oral scans, we merge them together, and one of the things that we found out immediately was, that her midline was completely off, just the way that her teeth were, of course, as preoperatively. And so we're going to try to straighten that out using the technology that we have to be able to merge together both facial overlays and the CAD/CAM STL files from our intraoral scans. And then we do our diagnostic wax-ups. So when we talk about restoratively driven, is that a myth or is that a reality? It certainly is a reality if we utilize the technology to our best possible advantage. And here, when we can see where the teeth are. Now, look at the green color of the maxilla, because now you can see that there's an overlay with that green color over the existing teeth, and now we can start to position our implants based upon where we want the screw access hole, based upon where we want the teeth. And so that is a really important diagnostic step. And then you can see this green line here. And what does that green line represent? That green line represents, or here a red line, represents where the bone needs to be reduced. So now we're going to do an alveolectomy, and I'm not going to bore you with all of the steps, but you can see step by step, and I plan all my own cases. I spend a lot of time going over and reviewing this. Just as Dr. Del Vecchio said, sometimes we want to get bicortical stabilization in different areas, and we want to be able to plan for that. We do crestal sinus bumps with osseodensification burrs as well. And then the 3D imaging shows where we can slice through the maxilla, and normally, in many cases, it's going to be at the apex of the root, depending upon how much bone that we have in the maxilla. I try to preserve as much bone as I can, but sometimes it's almost impossible. And the mistake that I see people making with the guided protocols, because I troubleshoot a lot of these cases, is that they don't understand the plane of occlusion, and they don't understand what happens posteriorly as they start to reduce the bone, and they accidentally, cut off the inferior border of the sinus. We don't want to do that. But we have all of these wonderful digital tools to be able to assess that bone, and then we can go in, and in this particular case, this is the chrome-guided surgery, that concept that we've been doing for many years, and you can see the first step that we're going to do is raise a large flap. We're going to position our fixation base by using a pin guide. This goes over those teeth. We're going to then fixate the guide with our anchor pins, and then we can see that we remove the pin guide and we have the teeth. So now we can go in and we can extract all of those teeth, and now we have holes in the bone. So the question is, do you graft those areas? Do you not graft those areas? And so even though we're putting implants in, you've still got a lot of areas where you have extraction sockets where you're not putting an implant in. And even when you are putting an implant in that area, you have space. And you want to be able to take that space and fill it with a graft material, in my opinion. And so you have these bony defects, both concavities on the facial, sometimes concavities in other areas as well. I mean, you can see here when we're trying to design our prosthesis, we want to be able to have, we don't want food traps in that area. When you have these big concavities, even though you have a beautiful prosthesis, if you have a concavity, you're going to have a problem. And so here we are with all of the teeth lined up. We don't use the teeth that have amalgams. I don't usually use teeth that have root canals unless it's absolutely necessary. We can cut off the clinical crown and just use the roots in some of these cases. And then this is the chrome guide concept of the bone reduction concept that I actually was the first to develop back in the early 2000s. And so now we have a metal guide. The fixation base is here. This is a stackable guide. If you haven't seen this, we're going to use this as our bone reduction. It does not touch the buccal surface of the bone. This actually floats over the bone, anchored in that area. And then we're going to use our autologous Dentin graft. And this, for those of you who haven't seen this is from Cometa Bio, another company. And we can get an enormous amount of bone graft material, autologous dentin, from these teeth. It's just truly amazing to me that more people don't understand how that's done. And so just to show you, this is after some of the teeth have been ground up. This is the top container here, the chamber, and you can see how much bone graft material. And this was from, I think, 1 or 2 teeth. This was at our live surgery course in Mexico. And then, of course, this gets treated before we can utilize it. That represented 2.5 cc's of bone. So now we're going to go to, once we do our bone reduction, we're going to go to our drill guide, which, again, is a stackable system, allows us to do full template guidance. We drill our osteotomies, we place our implants through the guide. As you can see here, we have those bullseyes. But pay attention to all of these areas of defect that we need to be able to fill. At least I find that need to be able to fill those areas. And then, of course, we're also placing many of these implants more towards the palatal region so we can have a screw-retained prosthetic result. So that means to me that you should be grafting just to fill all those voids, all those defects with a graft material. And then I test every one of the implants with our Implant Stability Quotient, our ISQ from Ostel, and we can go in there, we can use our smart pegs, and we can determine which implants we can load. So a case like this, which I did, we can see this implant had a very low ISQ value. It didn't have very much intermedullary bone, and we can see the 2 tilted implants here, but the other implants had very high ISQ values, and so we bury some, and then we load some. How else do you know? Not just from insertion torque, but that's another whole concept. And so, do you ISQ? I think everybody should. So when we have the ability to be able to assess the bone, we know which implants we can utilize. We then use our carrier guide to be able to place our multi-unit abutments. Notice that there's 2 pillars here, one here, one here. That's going to connect later to our prosthesis, which will sit on top of this. And then we can do full arch immediate load if we desire to do that. And so here's our multi-unit abutment cylinders. Then we can pick up the prosthesis. And we have so many different ways of doing this today. If you've seen our article on C2F, which is the small hole technology, which we published in Dentistry Today last year, that's another area that will make some of these articles available for you. And so now we can have immediate pickup of the prosthesis because it locks into that stackable guide, and we can fill the holes, we can fill the, that area, we can then remove it, fill in the defects, polish it up, and deliver it to the patient, upper and lower arches done at one time. And so there's a danger when we are bound by two-dimensional concepts when we live in a three-dimensional world. I always like to say that, but we don't really always practice that. So every course that I give, every live surgery, every lecture that I talk about, it's always the same. Regardless of what we're dealing with, we have to be able to assess the bone and then, the patient's anatomy, look at the bone so that we know what we're going to do. And of course, in 2000, well, actually, for years I published on this concept of brain-guided implant reconstruction, and the whole purpose of that is that we're using the technology along with our brains. The computer doesn't make these decisions, we do, because sometimes if we leave it up to just our brain without the computer, we end up having problems. And in my New York office, I end up having to fix a lot of these issues, and we can go from something like that to something like this. And actually, this patient just finished, and I wish I could have incorporated her video in this presentation. You know what, I'm going to skip over this just for clarity. But, technology has been around for a long time. Recently, when I was cleaning out my office, I found one of the first discs from Simplant version 1.1, and which I lectured on here in 1994. And here's some people remember what this is, little floppy disk. January 1994. So are we there yet? Yes, we're there on many different ways. And I presented some of this at the AAID conference last year when it was a webinar. We also use guided, navigational guided surgery in our courses and in our practice to be able to do this with virtual templates, not just static guides, but virtual guides. And so there's so much that technology offers us to be able to utilize when we're planning and executing our procedures. But the concept of guided surgery, in my opinion, is flawed in one reason, and that is because we have several oral surgeons here, periodontists, general dentists. We never agree where an implant should go in a receptor site. You put two dentists in a room, you're always going to get at least 3 different opinions. And so we can use the tools to narrow it down. Now, one other option here is that when we're doing a full arch, we don't have to necessarily take all the teeth out at the same time. We can stage that during the process. So here's a maxilla. Look at those teeth. They're basically pristine. We can go in, we can look at the pre-op, we can plan where the implants are going to go. We can see that we're going to have, areas that we're going to need extensive grafting to be able to build out for future implants. But there may be some areas that we can go in and place implants today, now. And so we can go in, we can do a staged approach, utilizing our surgical guides, by going in, taking our digital workflow, bringing this together so that we can create a guide based upon where we want these implants to go. We can then take our teeth out, but we do it sequentially so that we can go in, we virtually extract the teeth on our STL file that we create from our intra-oral scan, and then we can position the implants where we want them. We can create our surgical guide based upon this technology so that we can evaluate which implants can go in today, which implants have to be staged, and then we can utilize this for our grafting procedures. And so when we're dealing with all of these teeth that have to be taken out, we have a surgical guide for the placement of certain implants. After we've extracted some of the teeth, we can go ahead and place our implants. We can then take those teeth, we can grind them up, we can utilize them as autologous bone for our extraction sockets and for all of the areas that we need to bulk out so that we can place an implant in the future. And so here we are doing our full template guidance, and now you can see where there's some huge gaps in the extraction sockets. We've placed several of the implants here, and now this is all Dentin grinded bone. That's all autologous material from the patient's teeth. There is no other material that's mixed in there. I mean, I've gotten 10, 12 cc's of bone, and sometimes even more. Unfortunately, the Cometa Bio, they bring us these vials, and I keep telling them, tell us how much we're collecting. So there must be a way to measure that so that we can quantify. And hopefully that's coming this year. So now we have all of this grafting material. Now what are you going to do? What membrane are you going to place? How are you going to close this? And so this is, again, where BioXclude comes in. We showed you the PTFE. Dr. Devekian mentioned that. We took this picture before we cut all the tails there. But look at the amount of bone graft material that we can get in here. And you can see the white little starry areas. I mean, that's where there's, a mixture of enamel and with dentin. So we have the power to be able to diagnose. We have the power to be able to treatment plan. We have the ability to be able to then communicate this plan with all of our partners that we have, whether you're doing this yourself, whether you're doing it in cooperation with other clinicians, with your laboratory technicians, and you can't do immediate load without laboratory support, and then we can execute our plan. Now, everybody's concept of 3D imaging is a little different. I saw this once when I went to Las Vegas, and thinking about all the 3D printed models that we have, I never thought that we could create beautiful artwork out of it. So again, here's a case where we're going to do extractions, alveolectomy, surgical guides. We can go through this quickly because it's basically what we do every day now. We go in there, we use our anchor pins to stabilize this. We can see that we have placement of 6 implants, 3 in the anterior, 2 tilted, and now we have holes in the bone. What do we do with the holes in the bone? Well, we clean them out, we debride them thoroughly, and then we're going to pack our bone grafting material, because I don't believe that we should leave those holes the way they are. I like to be able to have a healed flat ridge with a broad ridge of bone, of nice healthy bone. So I'm going to graft on the buccal, I'm going to graft in all of the sockets, I'm going to fill all of those defects there, regardless of whether I'm going to come back and put an implant there later. I just want to have as solid a surface as I possibly can for the best healing that's available. And then we're going to go in and we're going to cover this with our BioXclude membranes. But here's another situation where when we're going to do immediate load, as you can see here, we have our multi-unit abutments. As you can see right here, you have all of these different defects, some of them on the buccal, some of them where implants are not. And then when we're dealing with multi-unit abutments, it becomes a little bit difficult because now we have to put the grafting material, and then we're going to have to suture around these multi-unit abutments. So as Ashley always likes to say, we can make a little X in where the smile is, and we can drape it over the multi-unit abutments. Or if we're going to use some of the collagen materials, we can also use a tissue punch and then be able to have that drape over that area, and then we can get closure around the areas with our covering the graft and be able to enhance our healing process. Now, there's different materials. Here you can see the difference between a collagen material and a thicker collagen material in this area, or sometimes, we've actually used a dermis material, which is also available from the Maxius company. And so when we have the ability to be able to utilize the properties of these membranes to enhance the healing process, we first have to start with the foundation of understanding what the anatomy represents, what it is that we need to achieve, not just getting the implants in. It's also about the whole biology of the system that's going to come later. So here you see 2 different membranes taken, for this photograph, so that we can see one that beautifully drapes over the bone, much easier to handle. This one has memory and starts to come up at you like this. And so what would you rather use? I would rather use the one that just drapes over really nicely. We can utilize our saline. We can add saturate the membrane, as Dr. Delvecchio said, and we can drape over it. Now, many times we have, broken down teeth like this. We're not using those for dentin grinding. Yeah, question?
Do you fixate the membrane?
Sometimes. Sometimes we'll use tacks to fixate membranes. But because we now, in a lot of those cases, especially when you have really, really dense cortical bone, it's become difficult to tack, we use deep horizontal stabilizing sutures that drape over the membranes and hold them into place very nicely. So, very good question. So here, just to show you in the maxilla, we'll go in there, we'll do our osteotomies. What are you going to do here? Look. I mean, see, everyone say, okay, great, we got an implant in that area. But what about that area here to the buccal of that implant? What about those areas buccal to the implant? What about the extraction socket in between those implants? I see so many clinicians, they don't want to take the time to go in there and graft these areas. The other pearl that I will give you is that if you think that you're taking this material and you're plugging it into that socket and it's reaching the apex, when you have blood in it like this or blood in it like that, it's not going to go in there. What's going to happen is that you're going to get some hydrostatic pressure or whatever to keep that bone. It's not going to go all the way in. So you need to use like a perio probe or something to get that, to place the graft material in that area, twirl it around with the perio probe, make sure that you're all the way down to the end of the socket, and then you'll be able to fill the socket very nicely. So here we're taking some of the teeth, and these teeth may have been taken from the mandible. So we can, if we're doing 2 arches, some of the teeth in the mandible may be better than the teeth in the maxilla. So I always start with the arch. If I'm doing 2 arches, I start with the arch that has the best teeth, so that I can then have one of my other assistants be grinding, cleaning the teeth, grinding the teeth, so that we can utilize them for our graft material. And then we can use a large BioXclude material. We can use our sterile saline. We can irrigate that, and we can then drape it over the graft material. It's just a wonderful material in all cases. It allows us to be able to just drape over there, and then we can suture it closed. And so we took the teeth out, in this case from the mandible, we ground it up, and we use it in the maxilla. And there are times where we'll use it in the for bilateral sinuses or sinus augmentation procedure. So again, this is all pending upon what it is that you desire as an outcome for the patients. Because this is what our patients want. Our patients want teeth. And when you can have a result like this is 4.5 years in function. We can look at the stability of that tissue. We can look at how we've maintained this architecture out here. Remember showing you the extraction sockets where there was this big, what happens if you don't graft it? Well, that area is going to completely resorb. And so I want to be able to keep that bulk, not just the bone, but the soft tissue that goes over it, so I can have an emergence profile that looks like this with beautiful soft tissue contours and the stability of that tissue. You can see how we created an ovite pontic area in that area. So in order to be able to do this and achieve these results, we have to pay attention to detail from a diagnostic stage to a stage where we can achieve predictable results on a regular basis. And so when we take a look at this tissue stability here, it really shows that we can achieve the results that we want based upon the technology that we have for diagnosis, treatment planning, guided surgery protocols, as well as using the biomaterials that we have today to be able to enhance our treatment results. This happens to be the x-rays from 3 years. We can see, again, the beautiful emergence profiles that we have for every one of these implants. We have bone growing over some of the areas here into proximal bone, and here's a little sinus bump on the upper right side. So can we achieve this success? Absolutely. Some of the articles that we've published recently, this is from Dentistry Today, Full Arch Surgical and Restorative Considerations with my dear friend and partner, Dr. Isaac Towell, with our AIE, our Advanced Implant Education. That's what we do several times every year. And so when we're using these materials, we have to understand what we're going to achieve. And from my perspective, what we're going to achieve is we're going to achieve healthy tissue. We're going to achieve an ability to be able to stabilize the underlying graft We're going to be able to deliver growth factors to those grafts that we're going to use. And when we have extractions and when we have defects, there are holes in the bone. And I don't like to be able to leave holes in the bone. So what do? We want to have proper diagnosis and treatment planning for all of the cases that we're doing. We want to do restoratively driven planning, and hopefully I've shown you some of the ways of doing that, although I tried to be a little fast to make sure that I'm on time. We want to understand guided surgery concepts. Today, I spend as much time, I had this discussion earlier this morning, I spend a lot of time, especially when I'm doing stackable guides, when we're doing guided surgery and we're doing surgical templates that have to be anchored to the bone. I spend as much time planning where the fixation pins are going to go as I do planning where the implants are going to go. So we need to be able to understand what that's represented with guided surgery concepts. And when teeth are going to be removed, you have every reason to graft to preserve the volume, which then preserves the soft tissue, which then enhances your emergence profile and your prosthetic result. Dentin grafting is also a viable alternative. It's not going, obviously you can't do a dentin graft if you don't have teeth, and you can't, but you can, as I mentioned, you can take from one arch and be able to utilize it for a second arch. So look at what you have available, because that autologous material is extremely valuable. When you combine that with the BioXclude membrane, you have the best of both worlds, in my opinion. So the use of amnion chorion membranes is extremely important in today's world. I'm so happy that they have it in so many different sizes. At some point it would be we should have a discussion over not just the rectangular shapes, but maybe we can introduce some other shapes. That would be nice in the future. And of course we need more education and we need more training. And so we use all of these materials, I use all of these materials in my private practice, as well as in our training courses with in different locations all over the world. Fortunately, we're now able to travel again, I hope. I hope this craziness in the Ukraine doesn't prevent us from traveling again across the pond, but we'll see what happens. And so 30 years ago, I came to San Diego, and I delivered a couple of presentations, and one of them was a poster presentation on communication tools for patients. And that became my book, which was published in 1993. So 1992, I was here at AO, and I presented a poster presentation. And this book is still being sold all those years later in 22 countries around the world. So I'm very, very proud of that. And this is my email address, drgans at drgans.com, if anybody wants to reach me. Again, these are some of the partners that we use for our courses. My partner, Dr. Isaac Towell, and Ashley can tell you about how wonderful the experience is. We teach sinus augmentations, we teach piezo surgery, we teach ISQ values. Certainly, we're teaching the use of dentin grafting, as well as using all of the Maxius materials and using all of the Snoasis BioXclude materials. And so we have the ability to be able to do that. I think there's some audio with this one, maybe not. And this will just give you a quick little preview of one of the facilities that we utilize this one's in Tijuana, Mexico, not far from here. And we have at least one faculty for every chair. We divide patients in the students, the participants, based upon their abilities by chair. And so if somebody has never placed an implant, we're going to give them patients that require that at that level. If somebody wants to do more advanced procedures, we assign them to a chair, and we assign patients to that chair that would have more advanced, more complex procedures. And I'm very happy to say that Ashley's there, rolling her sleeves up and helping everybody on a regular basis because all this training is needed. We know that for sure because we see the levels of the clinicians that attend our courses. We're very blessed that we have such wonderful faculty that join us there. We try to document most of the cases that we have. This is Dr. David Peck, one of our faculty, as Dr. Isaac Towell. And, we had a lot of problems during the pandemic. We're back in action. We just had a course not long ago. And then, of course, we always have to eat, and we enjoy that part of it as well. So with that, I think I should be just about on time, and I'd like to thank everyone for coming today, for your kind attention. I've now contributed to 17 textbooks, and I see Dr. Cullum is here because I think his textbook is in there somewhere. But we just came out with a new version. It's just coming out for someplace, maybe it's not there. Peterson's Principles. Oh, I don't have it on this. Oh, why did that happen? I don't have it on this slide. But thank you so much for your attention. I'm happy to answer any questions. I hope I covered a lot. I know it was a very, very condensed version, but that's what corporate forums are like. Thank you very much for your attention.